Invite Dr. Satish Khadilkar, neurologist at the Breach Candy Trust Hospital, and he is going to talk about DMD and other muscular dystrophies and novel therapies. Where do we stand and where do we go? Welcome, Dr. Khadilkar.
Good afternoon. First of all, I admire you all. You're still here on a Sunday evening, so many lectures one after the other. And I compliment Dr. Gulati for arranging this beautiful symposium. Now, what I thought I'll do for this, this particular meeting where pediatricians are supposed to be more than adult neurologists, I'll discuss the Duchenne muscular dystrophy largely. And then if there's time, then we'll go on to some others. So to introduce the topic, most of us know what Duchenne muscular dystrophy is. It's one of the commonest X-linked disorders that you see in the neuromuscular field. Affects 1 in 3,500 live male births, sort of more or less uniform all over the world with the same prevalence and incidence. And the boys, first of all, start walking on their toes, they start falling easily, they can't get up from the ground, and calves become large, they can't climb up the stairs, and usually it's easy to diagnose clinically. The CK is extremely elevated, and I think when you see in all the clinics across the country, when you see a young boy with very high CK and with this phenotype, almost always it will turn out to be a Duchenne muscular dystrophy, even though there are mimics. So genetically, what is the disease like? It's a large gene. Like Dr. Atisbiria just mentioned that there are large genes and there are small genes. This is one of the largest genes known in this area. It has 79 exons and multiple hotspots, some of them in the central region, some of them at the C-terminal. And largely, they are deletions. And that's one of the reasons why he told you that you don't do an NGS for the diagnosis of DMD. You do either a PCR with 32 exons or you do an MLPA. And 80% of the diagnosis of DMD will, you can make it on the basis of an MLPA or a PCR. Duplications are about 10%, for which you need the MLPA, which again, most of the Indian laboratories now have. So 90% of the genetic diagnosis, I think, can be made by an MLPA, by and large. And then there are point mutations. For point mutations, you need the NGS. And I think the panel that we now have locally in Mumbai, we include the DMD gene in most of the panels. So even what is between Becker and Limb-Girdle, it covers as well. And we also include Pompe in the, and I think, like you said, there are surprises every now and then. What looks like a dystrophy turns out to be Pompe. Right. Now you know that there is a similar disease, the Becker muscular dystrophy, which is like a stretched out form of Duchenne muscular dystrophy, where the onset is later, around 8 years to 10 years, and whatever happens in Duchenne happens slower in Becker. So what exactly happens? That this gene translated into a protein called dystrophin, which is a 428 kilodalton weight subsarcolemmal protein. And the protein is nearly absent in the severe form, and it is present to an extent in the milder form. So what makes this difference? Because the gene is the same. Some children are more severely affected, some are not that severely affected. So where is the problem? The problem is which part of the gene has been taken away by the deletion. And this cartoon shows you the concept of in-frame and out-of-frame mutation. An in-frame mutation is when the deleted portion is such that the remaining portions can join, to put it very simply, like you see in the middle frame. So if the remaining portions can join, a truncated form of the protein can be created, and therefore some protein exists, therefore some function exists, and you have a milder form. That's the in-frame mutation. Out of frame mutation is when the deletion is such that the ends of the cut segments do not match. So you cannot have a protein, and therefore protein is completely absent and a very severe disease exists. So by and large, most studies will say about 90% the frame shift hypothesis runs true, and if you have an in-frame mutation, it will be a Becker muscular dystrophy, and if you have an out-of-frame mutation, it will be a Duchenne muscular dystrophy. So the reading frame and its change has been one of the main areas where people work on. But let's come down a little. We are in India. What are the therapies available presently for Duchenne muscular dystrophy? I think corticosteroids. Probably they were equipoised for a while. From being equipoised, they now become the standard of care. But very interestingly, in the Asian Oceanian group, there was a recent study of all the countries included in the region as to how many people use steroids and which steroids they use. And there's quite a divided opinion. That paper is about to be published. A Japanese person has done the work. So some use and some don't use. Let me ask you a question. How many of you do use corticosteroids in whatever regime you prefer for Duchenne muscular dystrophy? 1, 2, 3, 4, 5, 6. So it's a divided house here also. Those of you who don't use, what are your fears? You don't believe that it works, or you're worried about the side effects? Anyone? I think it's both. There is a worry of side effects for sure. And in the Indian setting, weight gain is a big worry. Catching infections like tuberculosis is a definite worry in certain settings. And the general concerns of our people about the steroid. Now, steroid is a taboo word. I mean, when you say that I want to use steroids for your child, most of the parents will initially react unfavorably, and some of them will come back. So I think those are the issues that don't allow us to use steroids, as much steroids as we would like to use in this condition. In weight gain, I think it is the diet. When the child is interpreted as being weak and is therefore overfed. And I think most of the Duchenne children gain weight, and then you use steroids, and then they gain more weight. So in fact, weight gain, in my practice, I find the largest factor in monitoring the steroid therapy. Right. But I think there is no doubt that those people who use steroids and those patients who can tolerate steroids and follow up well, it definitely increases their ambulation time. And people are using it more and more. Initially it started with 6 months, then 1 year. Now, as long as you can use it and the child stays walking, I think you use it. So more and more people are using it. They're using it longer and longer. Then there are cell-based strategies, and I will come back to the cell-based strategies a bit. Then gene-based therapies, where functional copies of the DMD genes can be produced, and the exon skipping. So let's go to the drug eteplirsen. I think that's made some waves from 2013 onwards. And this is one article that in Jerry Mendel's group that I have taken out for you. Eteplirsen for the treatment of Duchenne muscular dystrophy. It's a very nice review and quotes many important things. It's in Annals of Neurology 2013. But what is the concept? Now see the top frame. There is a exon 50 deletion. 49 is present, 51 is present, 52 is present. Now this mRNA produces an out-of-frame problem, and therefore even though the deletion is small, it results in Duchenne muscular dystrophy when the combination is 49, 51, 52. Now if you have something that masks 51, it's like effectively a deletion of 50 and 51. So what results is 49 and 52, which is an in-frame mutation that is shown at the bottom of the slide. So if you have a method to mask one of the exons next to 50, you convert an out-of-frame mutation into an in-frame mutation. And that is what is the principle of the working of this drug. So it restores the reading frame, restores meaning converts from out-of-frame to in-frame with the potential of reducing the severity of the illness. And some functional protein results, and therefore the disease becomes like BMD. Now in September 16, the FDA has approved this drug, and the regimen is intravenous weekly infusions of 30 milligram per kg and 50 milligram per kg for 24 weeks. The outcome measures are 6-minute walk test and dystrophin in the muscle. Now there is trouble with both these outcome measures. You are all pediatricians here, so you know how difficult the 6-minute walk test is. Sometimes the child may just prefer to walk, sometimes the child may be lazy, sometimes the child may not cooperate. So 6-minute walk test, even though has been used extensively, the test as a measure has problems. About the second outcome measure also there are problems that in a given case of dystrophinopathy, you know that different muscles will express different levels of dystrophin. You can't take the biopsy from the same site again and again. And therefore, there is an issue as to what is your end point. Right. But at this point in time, there are 4 trials available, and the surrogate endpoint has been production of dystrophin. And the clinical endpoint is effect on the 6-minute, favorable effect on the 6-minute walk test. And the issues I have lined out, the inconsistent results of dystrophin expression, there is no known dose-dependent benefit. Some trials have shown a 10% increase in the dystrophin. Whether that's good enough to say that the child will improve is unclear. Clinical benefits sort of tapers down after time. So there are issues with trial designs of this drug, but there is some improvement that has been noted with this, maybe with better drug delivery and uptake, and to improve the antisense sequences, maybe with this drug itself, some more benefits may come. And I think this is another review in 2017, which I found covers all the aspects of what has happened around this drug very well. Is titled Eteplirsen, Drug Design, Development and Therapy, and is by Lim in Drug Development Therapy, and it's a recent paper, 1917. So if you want to look it up, this is a good paper to look up. Then I think the atalurin. In patients with nonsense mutation with Duchenne muscular dystrophy, there is a randomized multicenter placebo-controlled phase 3 trial with this drug, which targets the premature stop codon, and this is approved in the EU for DMD. It's an oral therapy. Now this is what it does. Again, the basic principle is the same, that frame A shows you the normal translation and the normal stop codon, which results in the normal protein. When you have a premature stop codon, there's an incomplete protein. And atalurin facilitates this translation, and it facilitates the function, the reversal to the functional protein, as shown in the 3 steps in this slide. So if you look at the current trial approaches in Duchenne muscular dystrophy, there's so many of them. I don't think any one of them has really sort of reached a point where you can solidly say that, okay, we really have something for these kids. Exon skipping, so many of them, which different exons to skip, 51, 45, 53. The nonsense suppression atalurin. I think the PTC is here, I saw them on this thing. PTC is going to run a multicentric trial of atalurin, and at least 10 centers in India are gearing up to deliver it. So I think sooner or later we'll see an Indian trial of atalurin. Then there are so many others. For want of time, we won't go in them. Next, the cell-based therapies. And I'm going to spend some time on this, even though most speakers on this subject do not spend time on stem cell therapy. And the reason is, there are so many stem cell centers in our country, and there are so many claims around the stem cell. I think all of us should know a little bit about what it is. And I might say that in 2016, the Indian Academy of Neurology instituted a committee under the guidance of Professor Gauri Devi. She was the chairman of that committee. And most experts, I think 15 or 16 experts were called, and they deliberated on what is the current status of stem cell therapy in various neurological disorders. And subsequently, this manuscript has been published in our national journal, so you can read it. At that point in time, not a single disease, the stem cell therapy was approved. It was approved in cornea at that time, which was very interesting to see the evidence in cornea, but I don't think even today it's moved on to any neurological deficiency. So let's look at Duchenne muscular dystrophy from a cell therapy point. What is the problem in the disease? Dystrophin deficiency. Sarcolemma breaks during contraction relaxation cycles. It leads to a myofiber necrosis and regeneration. The regeneration capacity gets exhausted. Then there is fibrosis and fat infiltration. That's the pathophysiology of the disease. So the objectives of the stem cell therapy is that you can divide them into two, early and late. Early is to restore dystrophin expression to stop or slow down the progression of the disease. And late, it generates new muscle, which is beyond gene therapy. So gene therapies largely will be used early in the disease, but stem cell therapies have a potential to be used later in the disease as well. Right. So there are three things that the stem cells should do or should be able to do. I've put them down in three different colors. The first is they should have a capacity to incorporate their nuclei into the patient's myonuclei, which is called gene complementation. The second step is the capacity to form new functional myofibers by fusion. And third is the capacity to have a pool, originate a pool of mononuclear muscle precursor cells so that it keeps on delivering the stem cells. So gene complementation, new functional fibers, and a new pool of cells. These are the three aims of the stem cell therapy. And this cartoon shows them that your delivered cells, the blue cells, you're delivered, those are the stem cells. They go into the muscle fiber that is in the center, that's the defective muscle fiber. The blue nuclei integrate with the red nuclei. That's step one, that's gene complementation. Step two is they form a fiber together. And third is, you see the blue cell on the top. They live there and keep on giving more stem cells. That's for the duration of therapy. So these are the three aims. So what have people been successful with? I think gene complementation has been achieved with as early as 2004. With gene complementation, you can see these dystrophin producing cells on the immunocytochemistry. So people can put in stem cells that undergo gene complementation and express dystrophin. Now the trouble with gene complementation is where you are given the stem cell, the changes occur in a very small area around where you are given the cells. It doesn't diffuse across, so you have to give multiple injections in one muscle. Now, has new formation of muscles been achieved? It has been achieved in advanced disease as well. And this is again, there is one person whose name keeps coming again and again, Skunk and his colleagues. And here he shows a 16-year-old DMD boy with DEL 50 with new myofibers formed due to fusion or transplanted myoblasts. So there is this human experimentation on showing the second step. And the new third capacity is the new pool of satellite cells, where again some researchers claim that the stem cells can be made to stay there and then keep on generating. Now, I think for want of time I'll skip some of the slides, but these are the evidences in published papers that they fuse, they produce the muscle fiber, and the satellite cells stay as well. Now the trouble is the delivery. How will you send the cells? So you've got to send them directly into the muscle fiber. That means you have to give them in an artery, and from an artery they go into that muscle. Intravenous is no good because it will get caught in the lungs. So multiple injections in each muscle, which is impractical. So delivery at this point in time is a problem. But that's the approach that the research takes, and this is a rat muscle being injected. Right. So I'll just show you, skip some of the slides and show you one local experiment that we did. I must also say that this particular thing came from funding from the parents from the Duchenne muscular dystrophy group. So here with the, in conjunction with a stem cell concern called Trans Cell in Hyderabad, we took out mesenchymal fat from donors. And mesenchymal fat is freely available at liposuction. There's so many Indians undergoing liposuction. There's a huge amount of mesenchymal stem cell available through the fat. So we collected some of that, and they moved it through 3 passages. We will skip the technicality, and I'll only show you that at the end of 41 days, after the 3 passages, you see these blue nuclei and the green cytoplasm. So dystrophin expressing muscle cells. So I think locally we have convinced ourselves that you can convert mesenchymal fat cells into myoblasts. Now we have done nothing further. These myoblasts have been injected in some people, but that's where we haven't as yet gone on. So I think basically in the last 2 minutes I will try and sum up. Primarily at this point in time, this disease hasn't found any satisfactory solution. We do use corticosteroids. There is a little bit of talk, or not talk, practice about using drugs that enhance the cardiac function before the cardiac function clinically gets affected. So most of my patients now go to a pediatric cardiologist. They have surveillance, and they are started on drugs like lisinopril pretty early on in the illness. So one is to dealing with the heart, steroids. Then early disease, genetic therapies, where the masking and exon skipping to convert a DMD into a BMD. The strategies like utrophin upregulation, which is an autosomal protein, which does a similar work like this X-linked protein. And in late phase, there may be a role of stem cells if it's pursued quite correctly. So I think that's where we'll stop. It's still 1 minute. Thank you very much.
Thank you very much, Dr. Khadilkar. We still have 1 minute from the session, so one burning question anybody would like to ask, comment?
Yes, sir. Sir, at this point in time, I don't recommend stem cells to anyone because I don't think it is formed, it's standard of care in any way. But patients take them, whatever you tell them. I examine all of them again when they have taken it and come back. I don't think much happens. So it's more of...
Thank you very much, sir. Thank you.
Thank you.
We move on to the next talk by Professor Andoni Utsibera. He's going to tell us now on riboflavinopathies, a new concept in child neurology.
Okay. Okay, so back on stage again. What about these diseases? Well, it's probably something new for you, but it's a key issue because it's a treatable disease, and that's good news, at a very affordable cost, as we will see in a minute. Those are the 10 commandments I used to deliver to my students in Paris about what should be done and what should be avoided. The first priority in all these neuromuscular diseases is to identify a treatable one. And they are. There are few, but they are. Myasthenia gravis, you can treat. Duchenne, to some extent, you can treat too, and so on and on. So keep this in mind. So the story started years ago, and more specifically in Lebanon, in Middle East. As a visiting professor, I used to go there regularly to see patients, neuromuscular patients, by the way. And my friend, who's a geneticist, André Megabanet, called me and said, well, we've got a weird family. I don't know what it is. It looks like SMA, but it's not SMA. And as you may know, Lebanon is a very peculiar country. It's quite unstable politically, and it's highly inbred. Everybody knows each other. They're all cousins. But they have different religions, and they marry within each religion. So the degree of inbreeding is very, very high. So for us, and for geneticists as a whole, it was like a gold mine. And it turned out to be one for the following case. So André presented this family, highly inbred, as you can see on the pedigree. This family is from the Shia community, it's a Muslim community from North Lebanon. And the phenotype was very strange because it was a drop head syndrome. You know, these children, after being initially developed this drop head by age 4 or 5, plus deafness, plus muscle weakness, and early death. That was the phenotype. So this was really impressive. There are different siblings affected in the family with a high lethality. And we had the opportunity to examine these kids together with André, and so all the same story. Normal at birth, onset around age 2 or age 3, hearing loss, muscle weakness, and bulbar involvement. This kid started, choking with dysphagia and sorts of things. And the phenotype was really devastating. They died very early, and we lost almost all kids in this family. Okay, so obviously we thought of a motor neuron disease plus deafness, but the point was that it was distal weakness. It was not, or it was limited, but it was not proximal weakness. So distal weakness, deafness, bulbar involvement, we didn't know what it was. And obviously there were no pyramidal symptoms, telling us that the CNS was fine. The MG findings told us that it was most probably motor neuron disease, and the rest was fine. The brain MRI was fine and everything. And they had a metabolic workup, it was negative. And obviously, because they had access to SMA genetic testing, it was not 5q SMA. Forget it. So we started being interested in this family. We haven't seen that family before. I mean, myself and many other child neurologists were with us. And we reported it as an autosomal recessive condition with severe drop head syndrome, with distal SMA, and deafness. And obviously, we had to browse the literature and to know what's known, what could it be? And you obviously know all this is in textbooks where there are different motor neuron disease, all sorts of them. There are probably 20 sorts. And one of them drew our attention, which was especially the bulbar spinal muscular atrophy, okay? And within this small subset of atypical SMA, you have this bulbar symptoms, and you obviously know the adult onset syndromes, bulbar spinal syndrome, like the Kennedy syndrome that all of you know, especially the adult neurologists, because in children it's extremely rare. So we had at least these different categories. But more interestingly was in children, that we knew some of these disorders as well, because they had been described in literature a long time ago, but they were quite unknown. Nobody paid attention. They were hardly reported in the literature. So, but still, we had this Fazioli-Londe syndrome and the Brown-Violletto-Van Leer syndrome. So, to make a long story short, it took us a long, long time, and this is the timeline for this disease, to link these disorders, the two ones I've been talking about, being described a century ago, with the genetic causing disease, okay, which is the riboflavin genes, as we will see in a minute. So all this is, again, a success story, and mostly resulting from NGS studies done in the 2000s. So these are just for your own culture, the myological culture, I would say. So these diseases had been reported by two Italian physicians a century ago. This is the case reported by Brown in the UK. And again, this is a summary of the phenotype for the Brown-Violletto disease syndrome. Again, the same story. So the most striking point is the deafness. It's not a congenital deafness. It appears gradually, by age 3 or 4. Before that, they're able to hear. And obviously, there are other cranial nerves which are involved. And progressively, the muscle weakness will expand to distal muscles, but also to proximal muscles, and it's an autosomal recessive disorder. What's the difference with Fazioli-Londe syndrome? Well, it's extremely simple. They're identical except for deafness. That's the only difference. So we reported this case and saying, okay, it's a Brown-Violletto syndrome, large inbred family from Lebanon. And that was in the 2000s, okay, at a time where looking for a gene and a gene defect was extremely challenging. And we had very, very few families. Some came from Pakistan, others from the Middle East. We had only one in France, and so on. So we had to pull all families together. We had to work with the Brits, which for a French is not something natural, but we had to do that, and we did it successfully. So there was a patient advocacy group formed in the US too, and Henry Hilden in London, I think it's Gosh, eventually found the gene. So we were quite happy. So that's what he described with others at the time. So they did, cloning, I would say, old-fashioned sequencing, but they found the gene, that's the point. And interestingly, they said, well, it's a transporter. But what does it transport? It transports riboflavin, which is vitamin B2. Okay, so that was the good news. So we were quite excited, but as you can see here, we were not in the paper. Perhaps because the Brits wanted to retaliate, I don't know. But the point is that our own Lebanese family was not linked with this particular gene. Okay, and the reason why is because there was a second gene. And the second gene was also a transporter for riboflavin. Okay, so now we have two genes similarly transporting vitamin B2 to the cell, and that's it. And when it's defective, when it's mutated, then gives rise to the so-called riboflavinopathy or the Brown-Violletto syndrome. Okay, so I will cut this short. So this is the publication where the second gene has been cloned and reported, and the Lebanese family we've been talking about was mutated for the second one. So this is the first gene. So be careful. The nomenclature is a bit confusing. Sometimes we use the SLC52A3 or RF2, and then we got a second gene, which is here, which is SLC52A2. It's the second one, but they also call it RF3, so it's been confusing. Anyway, the message is, yes, those two genes encode proteins that transport riboflavin. And we have different mutations in these different genes. The phenotypes do not vary from one gene to another. They're almost identical. So you can't base on that to predict the severity of disease. But the most exciting thing is that because it's a transporter gene, we immediately thought that perhaps giving riboflavin would help. So we started investigating the data about this particular biochemical pathway, and well, little was known about vitamin B2, but still we knew that it was a vitamin that you can absorb through the intestine, and then it was sent all over the body in different organs. So all this is pretty well known now, and you have at least 3 transporters, okay, which are located here. So obviously this vitamin B2 is useful for many, many things, including for brain, and that's probably why it's so damaging when it's lacking. So the pathophysiology of this vitamin B2 metabolism is pretty well known now. Okay, so that's a general scheme summarizing what we know about it. So riboflavin needs transporters to get into the cell, and riboflavin interact with different enzymes and plays a role in fatty acid beta oxidation and also in mitochondrial respiratory chain. I'll skip that. So in terms of biochemical profile, because many times I'm asked, well, can you detect the disease just by doing an ACL carnitine profile? And the answer is no, not always, and that's the point. Sometimes they have a normal profile, and these kids I've been talking about, okay? So it's not the most straightforward way to detect them. The best way to detect them is actually NGS, well, actually genetic testing, because the biochemistry sometimes may be misleading. So you can analyze the functional consequences of these different mutations, but that's, I would say, research-based study. So again, the diagnosis is mostly clinical and genetic. So interestingly, we started screening a lot of patients across the world, and it happened that the phenotype is actually much wider than expected. For instance, these patients may present with just sensory ataxia. They may present with optic atrophy. And obviously the other symptoms are usually classical, that is muscle weakness, hearing loss, tongue fasciculation, saying that is most probably motor neuron disease, and respiratory insufficiency. And that's why it's so devastating, because they die of dysphagia and respiratory insufficiency. So, in fact, it's much wider. And even at the pathology level, it's weird, because some of them underwent nerve biopsies, and the nerve is not normal, telling us that it's probably more complex than we think. Okay, it's not only motor neuron disease; it may be perhaps a polyneuropathy or something like that. So, just to make a long story short, and coming back to Lebanon, because 10 years later, the same friend in Lebanon, the same geneticist called me and said, "Oh, I've got a second family. I think they have the same." I said, "Oh, come on. Lebanon is such a small country, man. It's 4 million people. I mean, could you imagine having two?" And actually, again, inbred family, but not Muslim family, Christian family from the south. So not related with the other one. And same story, deafness, walking difficulties, and the initial diagnosis was axonal polyneuropathy. Okay. Again, the SMN1 gene was negative, no deletion. And there was a discrepancy between the phenotype between the girl and the boy. The boy was really severely affected, while the girl was mildly affected. She was more ataxic than anything else. So these are sister and brother, and as you can see here, the brother is really, wasted and is quite impaired. So, to make a long story short again, the same family turned out to have the same mutation as the first family, unexpectedly. And we were quite afraid that they would follow the same fate. It means they're very devastating and they will leading to early death. And we decided to put them on riboflavin, vitamin B2, high doses, as recommended by experts. And that's how they are now, 10 years later. Doing fine. Still alive. They're still deaf, both of them, but they're doing fine. Still able to walk. The child has still some degree of scoliosis, but still. So vitamin B2 is really, really impacting disease course. Okay, so that's how they are now. Just last year when we were so, okay, so they're all doing fine. So that's why we published this as a treatable childhood neuronopathy caused by mutations in the riboflavin transporter, RFVT2, which is another name for the same gene. But even more exciting, we've got new phenotypes now. We've got this very early onset phenotypes. I remember this Turkish family where this kid, she had been tracheostomized very early in age. She had bulbar symptoms. She was almost dying, but they kept on ventilating her for some month until we found through NGS that she had mutation in this particular gene. And she was given riboflavin, high doses again, and she recovered. No tracheostomy, nothing. She's able to walk now. She's doing fine. So it was good. And in the same family, actually, she had two cousins who died early. Okay, so that's good news. Okay, that's another story. That's another study done in Turkey. So Turkey, they had this two SIBs. This one is the affected one, severely affected, and once on riboflavin, recovered almost, not immediately. It takes weeks and months to recover, at least from a muscle perspective. And the sister, and that's interesting, the sister, which was known to have the genetic defect, the homozygous mutation in the same gene. So she was obviously going to develop symptoms over time, but we decided to treat her preventively. Again, same doses of vitamin B2. And she never developed any symptoms at all. Okay? Another story with the French girl. She was deaf since age, so the onset was much later, actually. And she had kind of a neurodegenerative syndrome. After age 10, she'd been tracheostomized again, ataxia. She even got a peg to be fed, so that was really bad. And again, we found mutation in this gene, and she dramatically improved on riboflavin. And she's now ventilator-free, and she decided to get married. She is married, and she got a child. She was happy ending, and she's the one. If you look at the literature now, there are more and more cases related to this riboflavin deficiencies, including, for instance, some unexpected cases like GBS-like or neuroimmune disorders. That's a very interesting set of observations related to riboflavin deficiencies. Some cases mimic mitochondrial disease. Yeah. They can find even ragged red fibers in their muscle biopsies, and so on and on. And we even have late onset in patients, adult patients who look like ALS, real ALS. And if you treat them, you can stop the progression of disease. So that's a particular case, I think, from the UK just 2 years ago. So, and so on and on. So, for the 5 minutes left, let me tell you again about India. India is actually a very good contributor to the Brown-Violeta-Van Les syndrome for different reasons. Because literature is full of case reports, such as the one from Delhi in the 2004, but also that was done from Calicut, from Kerala, from Brown-Violeta. So all these cases haven't been screened molecularly, okay? But most probably they had the mutation in one of those two genes. More interestingly, and that was done in Bangalore, on Madurai, sorry, and Bangalore, both. They found a double heterozygote, one mutation in the first gene and another mutation in the second gene. That's quite unusual and exceptional, but it's there, okay? And this is another case we reviewed with Dr. Nalini in Bangalore just last February. Inbred family from Karnataka, childhood onset, deafness, distal SMA, and riboflavin responsive. And we're still waiting for the results, but I can tell you that it's going to be positive. But the message here is that even you need time to wait for your molecular results. You can start these patients on riboflavin. And that was done by Dr. Nalini. And that girl, which was deaf and unable to write, is now getting much better, thanks to vitamin B2. Okay? Perhaps I'll show you the things. So, now there are still pending questions. Is the Madras motor neuron disease related to riboflavin deficiency? You know probably more than I about this disease because it's been described by Professor Gauri Devi's group and many other collaborators, mostly in South India. Motor neuron disease, some patients are deaf, but not many, and some are familial cases, as we know. So these are the initial descriptions. I'll go fast. But Dr. Nalini just showed, because she screened all these patients with the riboflavin genes and couldn't find any mutation. So it's definitely not linked to riboflavin, unfortunately. So the therapy is extremely simple, but you need to be active. In other words, you need to reach high doses, very high doses of vitamin B2. It's well tolerated, it's safe, it's very, very cheap, as opposed to nusinersen, and that's it. And it works clinically. So all this has been reported. I will skip that. So that's the take-home message. I've got actually two take-home. I've got another one. It's a treatable form of SMA. It's far less costly than nusinersen. The spectrum, the phenotypic spectrum, is much wider. Be careful. The nomenclature is not yet stabilized, and my guess is that it's extremely common in India. So what you need to do is to actually think of it and pick your patients up just by either screening them through NGS or waiting for NGS to come back. You can treat them with vitamin B2. So if times permit, where's the... yes, now we're day 3, are we? Yes. So perhaps I could just show you if it works, I'm not sure. Yes. So this is the girl from Bangalore. Perhaps you want to comment, Dr. Nalini, but she's basically very smart. She's got fasciculations and atrophic tongue, telling us that it's motor neuron disease for sure. And you will see when she walks that she's having distal weakness. You see she's got a steppage gait. Okay. So my guess is that she has Brand-Violato-Vanla syndrome. Okay. And the final take-home messages, and I'm back to my last previous presentation. It's about for those of you who are interested in the Paris summer school, we're running a course, a specific course for neuromuscular diseases. We trained 30, 40 Indian doctors in this 8-day course now. So you're most welcome. You've got the different contact details. You just need to send your CV, and we'll be most welcome if you want to attend. So that's usually in June. That's next June. And perhaps one day we'll have one in India. Fingers crossed. Thank you, Daniel.
Please stay back. So thank you very much. What was a fatal, progressive, degenerative, now it's become a treatable disorder thanks to gene identification. Any comments? Has anybody seen? Yes, Satish Khadilkar. Give him the mic, please.
Just a very brief comment that within the sensory spectrum, we saw a patient who had sensory ataxia and posterior column signals looking like B12. But the case is genetically proven. We gave only riboflavin and the signal went away. So, of course, she had the tongue fasciculations, she was deaf, she was young. So, there were a lot of suggestions of the Brown-Wieler syndrome. But her presentation was sensory ataxia.
Yeah.
There was a signal in the, so it was not only a radiculoneuropathy, it was a myelopathy, which came on the MRI, got better with riboflavin. And the second comment is on Amazon, riboflavin is available. It's quite inexpensive. And the high doses that we require are available on Amazon.
So thank you very much. I think it was a very instructive talk. Thank you.
So we close the session here and thank all the speakers as well as all the delegates who are here till late.